a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. With me as always, Adam Thacker, who's our Chief Operating Officer of Good Samaritan Hospital. We will be giving you our weekly update on status of COVID-19 in our community, some statistics on where things have been in the past few weeks, where we are now, a bit of an update on hospital status, and then talking a bit about what's going on with vaccinations, testing, upcoming boosters, those types of things. Probably first thing that we always lead off with, total numbers, about 5,320 total cases from the beginning, which doesn't mean a lot, but when we talk about the number of positivity rates, that's really what matters. About 9% all positivity rate, about 26% of unique positivity rate. And really interestingly, if we go back about the past 3 or 4 weeks or so, we have seen some declines in those numbers just in the past week or so, which is great. We're not slapping high fives and celebrating yet, but that's some much needed break, because I think that those numbers are also reflected in what we're seeing with hospitalizations also.
Yeah, which hasn't always been the case, but certainly that is good news. Cautiously optimistic, the word that we were just talking about, in that we've seen, with the community transmission declining a bit, we're seeing a little bit of a break in hospitalizations, the number of hospitalizations coming in. So we have been running 25 on average patients in the hospital the last few weeks, and about half to a little more ICU level of care have seen our ventilator capacities really stretched and strained the last couple of weeks. And starting this weekend and the first half of this week, have seen some relief in that. Still seeing about half of our admitted patients are ICU level care, just below half right now. But the ventilator needs have not continued to climb, which certainly is of good news. But the transmission numbers, while sound a lot better than 20% and 40%, 9% all test, 26% unique individual, is still very high from a transmission standpoint. It still fits in that category, if you were going to blanket it as transmission risk, as high risk, high sustainability. We're not taking masks off. We're not throwing out our hand hygiene and physical distancing. All those things really need to stay in place, especially as we're coming into everybody noticing, weather's starting to change a little bit, cooler seasons, moving more stuff indoors. That increases risk, as we've talked about many times.
Yeah, and really, as this wave has come along, we're cautiously looking at those state figures and then also nationwide statistics, and our previous big peak and then this peak coming up, and maybe rounding out the top of that and then maybe dropping off next few weeks. But just looking back as recently as 2 months ago, the numbers were a fraction of what they are now. So again, cautiously optimistic that we hope that those will continue to go down. But again, the push is still to make sure that, number one, we continue with our vaccinations. I'm getting lots of questions every day from my patient population, family and friends, about boosters, when that will all happen. But really the primary push at this point in time needs to be getting those that have not been vaccinated, because of all the patients you were just referring to as far as hospitalizations were concerned, overwhelming statistics that show that the highest risk patients that get admitted to the hospital are unvaccinated.
Yeah, we look at the data all the time, and what is it telling us, both from a local standpoint, state standpoint, and on a national landscape. And certainly the data shows anywhere from different areas in the country, from a 17 times greater risk of hospitalization if unvaccinated versus vaccinated, to some areas are reporting 30, 35 times higher risk. And then certainly, as you talk about each individual and their own risk factors, comorbidities that may make them more susceptible to a hospitalization, the vaccines continue to work. And when we're looking at some of the decline in our community, the first question is, well, why? What's changed? Seen a 10% increase in the overall population of Knox County being vaccinated. Have seen more and more vaccinations, certainly here. We've seen about a 13% increase in employees vaccinated at Good Samaritan over the last 2 months. And that is providing additional protection. Not to be all on one side, because certainly there have been natural infections that there is some immunity provided with that. We know that's not the long-term path forward, but that has provided some as well. But as we talked about last week, to get through to natural immunity, you have to have an infection that you have to live through. So that's a risky scenario. So certainly those have played in. And then when we start to look forward at vaccinations, late last week, the big news was the White House announcement from President Biden. The COVID-19 action plan, Path Out of the Pandemic, requires moving forward that all healthcare workers across the nation will have to be vaccinated. To some outside of healthcare, they probably saw that and thought, whoa, that's a big deal. But it's been that way with influenza, conditions of employment for vaccinations that we are just accustomed to. So we all anticipated it. We knew it was coming. It wasn't that big of a change. Obviously, some other elements of the president's plan were more sweeping and larger in scale, from Department of Labor looking at all employers 100 or more. Those are going to get tied up in discussions for a while. We don't have specific dates, but we know on the healthcare side that we're really looking at October dates and November, getting that in place before the flu season, the fall season where we saw big surges, and we're going to move forward with that.
Yeah, and we fully anticipate that similar type of pattern going into this year. We know that as temperatures drop, as everybody goes inside, more viral illnesses are spread around. But the precautions that were taken last year flattened everything out as far as influenza was concerned and many of our other viral illnesses. So we hope for the same thing this year. The question of boosting vaccines, so forth, again, not as important in our mind as getting your first vaccine. Right. Get out and get your first vaccination because that data is so overwhelming. But the question of boosters and who are candidates is percolating out there right now. Certainly the first people that we're concerned about are those individuals who have abnormal immune systems, undergoing cancer therapies, have immunosuppression because of their own diseases or because of disease treatment, things that we use medications to help lower their immune system so they don't attack themselves. So that population is certainly the first group that we're worried about with boosters, but other individuals are going to be candidates for boosters as well.
Right. And there's still some information to be released on that. So we know that Friday, so in just a couple of days, is the big meeting for CDC's advisory group, the ACIP, Advisory Committee Immunization Practices. And with that group, they're going to look at who should get a booster and when. So the initial information that was released had this date of September 20th, yep. And moving forward, everybody who had been vaccinated 8 months ago started to be eligible for boosters. And there's been a step back from that to say, okay, let's look at not just a time frame, but who really is at higher risk, which to some degree in the state of Indiana, that's already in place because the initial rollout was per risk. So the 8 months, if it follows that, will also be per risk. But really looking at healthcare workers, our elderly population, at-risk population, certainly nursing home populations, although they already have kind of in place a mandate. But as you mentioned, it's looking at immune system and who might not have the adequate response, or who, if came in contact with the virus, would have a more difficult time with that. So more information to come in that piece. Those that are immunocompromised are actually eligible and getting a third dose vaccine now. When we get to September 20th, that's when things move forward, and really within probably next week when we're on here, we'll be able to say, okay, there's been some guidance from that advisory committee to say this is what the eligibility looks like. Pfizer submitted for full FDA approval of their booster, so that's being reviewed. Same dose, same formulation. I've gotten that question many times. Yep. One thing that has, I won't say thrown a wrench in it, but created more review is Moderna submitted for their booster as half the dose of their initial. So that requires a much more in-depth review to say, will that dose gain the response that we know that the full dose did, and why, and all of that. And then you throw into it the other piece that's being looked at very heavily by the FDA right now, and I think it's probably number one actually on the priority list, is ages 5 to 11. Mm-hmm. There's discussion that by October that will be approved under emergency use authorization, and I think that when we talk about unvaccinated populations and they need to go first, that's a group that just by virtue of eligibility, not by hesitancy,
Right.
is unvaccinated. And so I really think that's probably at the top of the list for moving that along.
And that population is a population we've seen a tremendous surge in just in the past couple months or so. We were not nearly as concerned about our pediatric and adolescent population last fall as we were going into this. There were very few cases. There were very few cases that were getting terribly ill. But as we discussed last week, our tertiary care facilities, our own inpatient pediatric services have been extremely busy lately with admission of viral illnesses. And so that population, looking at vaccination with them, is very important to all of us. We would still ask that people be very cognizant of what their symptomatology is. As we've talked about every week, one of the keys, along with vaccination, is identifying this illness early, getting tested early, and then appropriate quarantine and isolation precautions. And so that, the beautiful thing about it is that's readily available. If we go back a year, you and I were having discussions as to how many tests were available, how quick those tests would come back, PCR tests, 7 to 10 days, 2 to 5 days, so forth. Not an issue anymore. So we have multiple facilities now that are offering that testing, and that antigen testing comes back very quickly, about 15 minutes. Tell us a little bit about where those facilities are and how people get tested here locally.
Sure. We have 3 sites. Our 3 sites are convenient care sites at Willow Plaza and then at Williams Brothers. And then we have a 3rd site at the Medical Center of Vincennes around on the back side of our MCV building. So there's different avenues to access that. From I was exposed, I have some mild symptoms, want to be tested, don't necessarily need to be evaluated by a provider. I can go online on our website and go to convenient care and click a time to test. We have test availability this afternoon and throughout the week. Also, if you're a MyChart user, meaning that through our Epic system, you have MyChart patient portal where you get all of your health information. Certainly, that's an app-based approach that's very fluid, very easy to use. You can select a time. Actually, when you go on there, you just hit COVID testing, and it all pops up, and it guides you through it, and it's just kind of click and go. As far as being evaluated by a provider, our convenient care sites are open into the evening hours and can be evaluated by a provider. Certainly, as we talk about each week, that's important for anyone at risk that needs to be evaluated, and potentially outpatient therapy with our monoclonal antibody treatments that have shown to have tremendous results in keeping patients out of the hospital. But those 3 sites, even though we've seen a little bit of a decrease in testing, still very busy, and being able to schedule that, one thing that's important to know is, I think initially I got feedback when we heard, oh, you're going to schedule it, is that we were limiting the number of people being tested. We actually built the schedule to meet the maximum numbers that we were seeing, but now those 200 people are coming in over an 8-hour period of time versus 200 people show up in the first 2 hours and then get told it'll be 5 hours. So it works better for everybody once we got some of the bugs worked out, and that team out there at our convenient care sites are doing a phenomenal job.
Yeah, considering that a normal workload in that facility is 40 to 50 patients, the fact that they're dealing with 170, 200, 230 patients is tremendous. So yes, the scheduling portion of it, I was out there pre-scheduling, and I can tell you that's exactly what we saw, were big waves that would come in, a lull, and big waves. So essentially spreading that out over a longer period of time has been helpful. It's been a satisfier for the patient population, and having those after hours available slots is tremendous, especially with the populations that work, and also for kids that need to be tested. So those facilities that Adam referred to are available for not just adult testing, but also for pediatric testing as well. We are discouraging people to not come in for asymptomatic testing. That really doesn't help them. That doesn't help us. It doesn't change anything associated with care, and if anything, potentially gives people a false sense that they are negative prior to the time that they would have potentially turned positive. Some people will get a little confused about testing whenever they have to go do testing for travel or other work-related items. That's not what's applicable here in terms of what we're talking about.
Also on testing, I think it's part of the federal plan, the President's action plan, but also we're seeing it happen a little bit more here, that home testing is becoming more widely available.
Yes.
It's a great resource that individuals are going to be able to go to local pharmacy, pick up an antigen test. As we've talked about, the antigen tests are the same that we utilize.
Yep.
I think it's important that the community recognizes in the medical field, we do not use home test results as diagnostic information. Calling in with, I swabbed myself, I'm positive, and now what do I do, is not going to get a provider to treat you over the phone based off of that information. We're still going to need to provide that test. There's technique involved, there's timing involved. Situation that came up just this week was patient tested at home twice, negative, came into the clinic day 3, tested positive. Well, in all likelihood, the timing of testing just hadn't materialized to that post 5 days to where we really start to be able to detect the virus, or the technique. It's a lot easier for somebody else to stick that Q-tip up your nose than it is for you to stick it up your nose yourself to make your eyes water and want to do that and follow that technique correctly. We have individuals that are doing it hundreds of times a day.
Yep.
So just as a word of caution, and this isn't unique to COVID, the medical community doesn't accept home tests as diagnostic tools really across the board unless those home tests were given to you by a physician, by a provider to say this is how we use it. So I think that's going to be an important note as that access is going to grow, but it's not a diagnostic tool from a medical standpoint. Now, if you use that to self-quarantine
Yep.
and use it in that informational type of avenue for your family, that is its intent, just not in the medical side of things.
Yeah, and when we look at that basically leads us into the question of what to do as far as treatment is concerned and monoclonal antibody treatment. So the same rules apply as we have discussed for months, and that is that we want to identify patients early in the disease course who have a positive test, who have risk factors. And those risk factors have remained basically the same as we have moved along through this. Chronic comorbid medical conditions, diabetes, emphysema, asthma, immunosuppressed conditions, cancer therapies, patients who have chronic kidney disease, chronic liver disease. All of these things are comorbid factors, along with simple things such as hypertension, obesity. Those are significant risk factors that we have seen associated with risk for hospitalization with COVID-19. And identifying those patients early, being within the first 7 days of onset of symptoms, so they can receive monoclonal antibody therapy. We have administered over 1,000 doses of that since we started that process 9 or 10 months ago, and have seen tremendous results. Primarily with the goal of that is intervening early, turning the course of that disease, illness around, and reducing hospitalizations. And really what we have seen statistically with our own numbers compared with what's been seen nationwide is a tremendous reduction in risk of hospitalization and also mortality.
Right. It really has been great results. Word of caution that we spoke about, it is not in lieu of vaccination. Yeah. So vaccine, preventative medicine, that certainly is the standard that we need to move towards. What monoclonal antibody treatment allows for is those individuals at high risk and trying to head it off early, neutralize the COVID virus, and keep patients out of the hospital because these individuals are at high risk. And as you mentioned, the two there at the end, hypertension and obesity, as we're starting to get more data and be able to kind of slice and dice things, those are the two groups, risk factor groups that we're seeing the most of. And many times people, you ask them about medical conditions, and they name a few and they're, oh, and I have hypertension. They just don't think of that as my high blood pressure as a medical condition. And with COVID, it's a pretty significant risk. But yeah, we're seeing, 95+% of patients getting treatment have been able to stay out of the hospital. But again, we go back to had to test positive, had to be high risk. That's not always going to be the case. And there's still some individuals that are going to wait too long. And just this week, we're talking about those individuals got to treatment, but just this week we had a few candidates that unfortunately got worse, needed oxygen, needed hospitalized, and then you're no longer a candidate because
Right.
This can only be used in the outpatient setting. That's the only approval is in the outpatient setting. So there's still a lot of risk with looking at this as, I won't go down the vaccine route because there's this treatment. Not to mention availability is really an everyday management of trying to make sure we have enough monoclonal antibody to take care of the patients that are eligible.
Yeah, absolutely. And that early intervention, identifying that population, the approach should not be I'm going to wait and see if I get really sick, and then once I'm really sick, I think I'm going to go get evaluated for that. That is absolutely not the most appropriate way to utilize this modality. It is identify that you're positive, identify that you have risk factors, and get that treatment as soon as possible. And that applies in the pediatric population as well. Although there are a much smaller portion of that population that have risk factors, those children and adolescents that have asthma, diabetes, have had cancer therapies, immune system problems, those children and adolescents are identified as candidates for this as well. And although we haven't given a lot of that over the course of the last few weeks, we have had several patients that have benefited tremendously from that early intervention, preventing them from getting as sick.
Right.
So as we move along as far as testing, vaccinations, monoclonal antibody, any particular things that have changed as far as hospital policies are concerned with visitation, those types of issues?
Our visitation remains the same as it has been for a number of weeks now. In our ambulatory outpatient settings, really it's no visitation other than for transport mobility reasons, for family to assist with, or in medical decision making around a procedure or care that's being delivered. The best practice is still keeping traffic at a minimum within the hospital. And then in the inpatient settings, can have 2 visitors, are able to manage that as patients come in. We do have screening stations in place as part of late last month, the new requirements around screening. So patients and visitors, vendors, anybody that comes into Good Samaritan, absent employees, have to stop at a screening station. We'll be asked about any COVID symptoms, any recent exposures to COVID, and if you've had those and are a visitor or really for non-essential business reasons, you should not be in the facility. And just to clarify, say employees don't have to do that, because employees are doing that through their departments on their own, self-monitoring and reporting through our employee health avenue, and that's why screening of everybody else is so important.
So a number of people have asked me frequently about what things they should do to try to stay healthy, and those things are strikingly like the same things that we tell everybody all year round, regardless of COVID. And that is, it's important to stay hydrated, it's important to eat well, it's important to sleep well, it's important to exercise. There's lots of information out there as far as taking this supplement and that supplement and a whole variety of things that probably isn't necessarily harmful, but there's not necessarily a lot of data to support that. So we get asked that on a routine basis. The majority of things, as far as supplements and vitamin things, there's not a lot of data to support that. The majority of those things, including vitamin C and zinc and calcium and vitamin D and so forth, in reasonable amounts are certainly not harmful, but we would caution people that the main things to stay healthy are what we should all be doing daily, which is eating properly, staying well hydrated, exercising, and getting good sleep. As we move on into the fall and we see that those other viral illnesses and so forth are coming up, flu season is obviously going to be approaching in a few months or so. And although we did not have a bad flu season last year, primarily because of all the precautions for COVID, those vaccines are becoming available right now also.
Right. And so as they become available in September, there's a few things that happen really every year. We start evaluating any patients that are admitted to the hospital for have they had their annual influenza vaccine, and then we offer and provide that as part of being in the hospital. Also next month we will be mass vaccination for our employees for influenza as well as COVID, and we will be having community drives for influenza vaccine as well. We'll get those dates out specifically when they are. And as we did last year, looking at drive-through mechanisms to be able to do that. Last year, one thing that it did create was innovation around how to do things a little bit differently, and we're able to have some drive-through style influenza vaccinations. Also, our community health team does go out to a number of areas, whether it is senior living areas, to employers, and all kinds of various avenues that we'll be able to provide that. But certainly as we move into a flu season, with masking, we're in all likelihood going to see a lower flu season than what we have seen pre-pandemic days. But nonetheless, there will be a flu season, and we certainly want to, that's not a reason, so the mask is not a reason not to get vaccinated for the flu. We still want to keep up with that and not have that, that really spike up in our area.
Yeah. Any other issues to hit before we go to the phones?
I don't believe so.
just a couple today. The first one, this person has had the vaccine and now they have COVID. Does she need to get the booster?
Yeah, so this brings up a topic we discussed a bit last week, which is who are the best prepared people from an immune standpoint. So this individual was vaccinated. They now have COVID, and their question is, do they need a booster? When can they get a booster? Most importantly, to realize that that person having contracted COVID after being vaccinated is very well protected at this point in time. We know that some of that natural immunity helps out. We know that the broad spectrum of protection that the vaccine offered is helpful as well. They are eligible to get a booster anytime once they're recovered, but as Adam was alluding to, the ACIP, the organization that really helps us from childhood vaccinations all through adult preventative vaccinations, is going to go through and give us a little bit more direction on stratifying that. And as you said, kind of naturally in the state of Indiana, because of the way the vaccine rollout worked, those populations are kind of already naturally stratified because of who was eligible first, people over the age of 80 and then 70 and then 60 and then risk factors. So that's going to roll out 8 months to follow in the population. So in this individual that they're talking about, not an urgency right now to go get vaccinated, to get that booster, because that individual is probably one of the most protected people that we have now.
And I would just add that, because I kind of hear it in the question, maybe I'm just going there, is that the fact that had the vaccine and then contracted COVID doesn't mean you need the booster because the vaccine doesn't work. The vaccine, as we've talked about many, many times, is geared at keeping you out of the hospital and keeping you from dying. And I'm assuming the two questions, because we got that question on Facebook, individuals not in the hospital and not dead.
Yep.
So as we look at that, the vaccine's working, and now, as you mentioned, you have that added layer of natural protection.
Yep.
Okay. How far apart should someone get the flu shot and the booster?
You actually can get them on the same day. Initially, when the COVID vaccine came out under emergency use, the recommendation was no other vaccinations given within 2 weeks. That was not because there was a worry of interaction or health. It was truly from a administrative standpoint that if there were side effects, we want to know it was from the COVID vaccine and not from anything else. That recommendation has now been removed because we're north of 380 million doses and have seen very little side effects and concerns. So you can get them on the same day. You can also space them out. There's not a recommendation that you have to. A lot of that is just kind of knowing what your past response has been from vaccination. Some people feel pretty tired, pretty crappy for a day. Some didn't feel anything but a little bit of arm pain. So it's just kind of knowing how your body's going to respond that 24 to 48 hours after vaccination.
And really, the vast majority of the patients that I have had that have been vaccinated reported nothing. Basically, that they had no side effects, no symptoms, not even arm soreness. We do have some anecdotal reports of people who had previously had the illness that then got vaccinated that had more arm soreness, which of course makes sense because that immune system is already charged up and ready to go, and we're basically helping to make sure that it has a more diverse profile of virus to attack that way.
That's it.
Fantastic. Any other things from your standpoint?
I don't believe so.
Okay. Well, thank you all for joining us. I would just caution people that as we move forward, to look carefully at the sources of information that you're gleaning. We deal with everyday individuals that have gotten information from questionable sources. Those sources, unfortunately, are from people that sit on a throne of lies, and you need to be very cautious about where that comes from. We tell people to seek out sources that are reliable. Tertiary care institutions, Barnes Hospital, Northwestern Hospital, Cleveland Clinic, Mayo Clinic, these type of institutions. They don't have to be government institutions. I know there are plenty of people that are not going to go to the CDC's website or other places because of other beliefs, but going to reliable medical institutions is a great source of information. That's where a lot of the data and a lot of the study reviews that we do come from, so we would encourage people to follow up with places such as that. Looks like we had one sneaking in under the wire.
Answer it. What if J&J does not have a booster?
So currently they do not have an approved booster, and as of, I looked yesterday, had not even submitted to start to go down that path. So really what we're looking at right now is that all of our booster conversations are around the mRNA vaccines, Pfizer and Moderna. Recommendation is not to go get booster of a different vaccine and interchangeability. Once that is submitted, which it looks like it will be, there will be a booster process and approval for Johnson & Johnson. I think the big word of caution is for those that were vaccinated with J&J, hospitalization, risk of death is still very, very highly protected against with that vaccine. There's no reason to think I got to run and get the Pfizer vaccine or Moderna vaccine. Wait as that information comes out, and then those recommendations will become more clear.
That's it again.
Okay.
All right. Well, thank you all very much for joining us. We'll be back with you again in a week.